This next section is calcium disorders, hypercalcemia, hyperparathyroidism, and hypocalcemia. Hypercalcemia is a frequent finding for in-hospital patients. It's a very unusual finding for the ambulatory patient. Vitamin D intoxication can occur because vitamin D is a fat-soluble vitamin. Therefore, it can build up to toxic levels. Water-soluble vitamins, such as B vitamins and C vitamins, are rare to have toxicity because they don't build up. They just go out into the urine. Sarcoidosis and other granulomatous diseases cause it because sarcoidosis actually creates more vitamin D, as do the other granulomas. Thiazide diuretics are a cause of hypercalcemia by increasing calcium reabsorption at the distal tubule. Hyperthyroidism, how does that happen? Well, hyperthyroidism causes an increased metabolic activity everywhere in the body, and it also does so on the osteoclasts. So it becomes sort of like mania of the osteoclast, and it dissolves bone. Metastasis to bone and multiple myeloma. Well, multiple myeloma certainly has a very clear mechanism of activation of interleukins, which also melt away bone with osteoclasts. Metastasis to bone is simple bone destruction. And the winner for the most common cause of hypercalcemia is primary hyperparathyroidism. And the reason that this is by far the most common is that most cases simply are asymptomatic. And it turns out that severe acute symptomatic hypercalcemia is more common with cancer. For instance, if you take every 100 people that simply have hypercalcemia, hyperparathyroidism is the most common. If you take every 100 people who have a symptomatic hypercalcemia, far more of them might have cancer, because cancer just presents in a very, very severe person. Acute symptomatic hypercalcemia is mostly based on the fact that high calcium levels make it harder for neural tissue to depolarize. Calcium actually pulls the resting membrane potential away from threshold. Threshold is the point at which neural tissue depolarizes. So if you increase the distance between threshold and the resting membrane potential, it makes it harder to get up there. It makes it harder. It's sort of like raising the passing grade on step 2. That's exactly what that's like. And that would make you confused, lethargic, and stuporous as well. And now this is not just happening in the neural tissue in the central nervous system, it's also happening inside the bowel. Remember, the bowel is a big, long, muscular tube, and it just makes it harder for it to depolarize, and you get constipation. If you don't contract the muscle of the bowel, stool can't go forward. And if stool can't go forward, you get constipated. So it's basically stupor of your bowel. It's bowel stupor. Bone lesions such as osteoporosis can also occur when people are acutely symptomatic, but that has more to do with the fact that osteoporosis leads to the hypercalcemia rather than the person who is hypercalcemic getting osteoporosis. It's the fact that things that melt out the bone causing osteoporosis are found in a person who's hypercalcemic. Kidney stones the same way. Well, kidney stones, nephrolithiasis, because you have more calcium, of course, to form the stone. It's supersaturated. It's like making rock candy. It just precipitates out into the kidney. Diabetes insipidus is because you have a nephrogenic diabetes insipidus. Basically, a very high calcium level makes it so that the ADH does not work at the kidney tubule. This results in a profound water and volume loss. And this is one of the most important things mechanistically, so that you understand that in hypercalcemia, it's not just an osmotic diuresis from the calcium. It is the fact that the high calcium simply renders antidiuretic hormone ineffective at the kidney tubule. So you just urinate out 10 and 12, 14, 18, 24 liters a day. Renal insufficiency is common in presentation because of the massive dehydration. Now, since it's a pre-renal azotemia, it can often resolve once you hydrate the patient. Because you have an effect on neural and muscular tissue, it's natural that both low and high calcium disorders have an effect on cardiac conduction. And when you have hypercalcemia, hyper gives you a short QT. Hypo gives you a long QT. So long in hypo that you have an arrhythmia. Acute hypercalcemia is treated predominantly well. Think of the mechanisms. Now, you may have noticed that I gave you more things on mechanisms in this section than many others. And that's because if you understand the mechanisms, you'll be able to understand all the therapies. The symptoms of lethargy, confusion, disorientation, the symptoms that might be related to renal insufficiency, a lot of this comes from the fact that there is a massive diabetes insipidus and volume loss, both osmotic loss of the calcium as well as loss of simple volume. So therefore, the number one therapy is massive volume replacement with saline. Massive volume replacement with saline. The most common wrong answer is to say loop diuretics. Loop diuretics, such as furosemide, are no longer standard of care for acute hypercalcemia in a person who's able to make urine. In any event, they were never correct before hydration. Hydration by itself will solve the vast majority of the problem because hydration will correct the pre-renal azotemia. Hydration will simply correct this massive volume loss, and you'd only be giving the diuretic to a few patients who simply can't make the urine. That's a very big and important point. Bisphosphonates such as pamidronate, zoledronic acid, well, pamidronate has simply become the bisphosphonate that we use most frequently in acute symptomatic hypercalcemia. You could use any of them, and it's a class agent. It's a class effect. But the thing is that pamidronate, if you have to choose one single one, that's the one, followed by zoledronic acid. Calcitonin has one function that we notice on a regular basis, and that is it works fast. Now, it doesn't last long. There's tachyphylaxis. Tachyphylaxis means it wears off. $5 word for wear off. What's the difference between wearing off and tachyphylaxis? $48,000 a year of tuition. That's the difference between those. Now, while you're doing the hydration, sometimes it doesn't work fast enough. And bisphosphonates take 2 or 3 days to work, 4 days. It'll take a couple of days to work to get that calcium into the bone. Calcitonin has the function of instantly inhibiting osteoclasts. Calcitonin is like the bumpers on your car. Unless there's a problem, unless you're in an accident, you wouldn't notice them. That's what calcitonin is like. There is no deficiency disease of calcitonin ever described and no excess disease. It exists as a therapy for acute symptomatic hypercalcemia. It's a 3rd or 4th line drug for osteoporosis sometimes, but it's for symptomatic severe hypercalcemia while waiting for the bisphosphonates to work. Prednisone is only when it's sarcoidosis and granulomatous disease. Prednisone by itself is not going to be good in the long run because steroids cause osteoporosis themselves, but it will control the production of the vitamin D inside that granuloma. A 75-year-old man with malignancy is admitted with lethargy, confusion, abdominal pain. He has really high calcium. After 3 liters of normal saline and pamidronate, his calcium level is still very high. Even on the following day, what's the next step in management? And the answer is calcitonin. Calcitonin's function is to lower that calcium acutely. Zoledronic acid is a second bisphosphonate. And there's no point in using zoledronic acid when you're using bisphosphonate, because it's like wearing underwear on both the inside and the outside of your pants. What's the point? It's double coverage, it doesn't help you, and it makes you look a little strange. Plecamycin is ancient history, and the same with gallium. Plecamycin and gallium are here because I can never quite tell who's reading old materials. And that is why people can have the give furosemide first story. That is the most common wrong answer. Furosemide is only in people who are unable to make urine. So you may see it in old questions in places, in old versions of books. As a student with a limited budget, well, a big budget, which is limited to your tuition, I would say that you may be making a decision, should I buy that book? If you look inside and it's telling you to use furosemide, the answer is no, and you can burn it to heat your house. Plecamycin and gallium are always wrong. That's old stuff. Bisphosphonates eliminated them. Dialysis will work, but you simply don't need to do that, okay, because you can control it with saline and bisphosphonates and pamidronate in the majority of cases. And cinacalcet is a drug that we use to inhibit parathyroid hormone. It is a calcium mimetic agent, a calcium mimetic agent, cinacalcet, like a little calcium. And what it does is it causes a feedback inhibition on the pituitary, and it can be useful in shutting down people's parathyroid hormone release, particularly people who have a pathologic secondary hyperparathyroidism. Primary hyperparathyroidism, very common. It's caused by a solitary adenoma in the vast majority, in 80 to 85%. And adenoma is very common in endocrinology. If we go from the top down, we will see that prolactinomas are adenomas. Acromegaly with growth hormone is an adenoma. Cushing's with an ACTH-producing adenoma in the pituitary, also same thing, hyperfunctioning, as well as in the adrenal gland. Hyperfunctioning, Conn syndrome, primary hyperfunctioning adenoma. Now, one of the reasons that you'll be able to recognize as an adenoma is that it's hyperfunctioning. It's like cellular neurosis. It's not malignant, it's not going to kill you, but just a little overfunctioning when it shouldn't be. So hyperplasia of all four glands occurs, and malignancy is a very unusual entity for the hyperparathyroid etiology. And remember that cancers, malignancies, simply don't function. Remember the thing about the thyroid? One of the ways you know a nodule is not cancer is that if it's hyper-functioning, it's not cancer. It doesn't need to be biopsied. Because cancerous cells don't hyper-function. They don't function at all. That's one of the ways you know that they're cancer. Elevation in calcium, when it's asymptomatic, is occasionally removed. So just because it's asymptomatic doesn't mean it's benign. It means we might remove it anyway if it causes some renal insufficiency. But when symptomatic, it causes osteoporosis. It causes kidney stones and renal insufficiency and muscular weakness because high calcium levels inhibit neuromuscular transmission. The anorexia, nausea, vomiting, abdominal pain is for much the same reason that you get constipation, which is that if you can't contract your bowels and move them normally, things just get stuffed up. It hurts, it's uncomfortable, nothing's moving through. Peptic ulcer disease is very hard for people to understand until you realize that calcium is a stimulant to gastrin as well. Calcium causes acid. Doesn't that make this a little bit like a Zollinger-Ellison? And the answer is yes, it does. Besides high calcium and PTH levels, you'd also find a low phosphate level because parathyroid hormone excretes phosphate at the proximal tubule of the kidney. And there's a short QT, but that's not particular to PTH. That is basically because all high calcium makes a short QT. Sometimes there's an elevated BUN and creatinine based on how much volume loss there is. And alkaline phosphatase is elevated from the effect of PTH on the bone because parathyroid hormone dissolves bone. That's why we're in this section, because that's how you get hypercalcemia, because PTH melts bone. And an asymptomatic byproduct of that is alkaline phosphatase. But these are all key issues, because if you have bone effect and kidney effect, even if you're asymptomatic, you gotta get those parathyroids removed. If most hyperparathyroidism is asymptomatic elevation in calcium, then why do anything about it if you don't feel it? Oh, ding, ding, ding. Answer is, if my kidneys and bones are getting hurt, get rid of it. It's like termites. You don't need to wait for the building to fall down to get rid of them. And how you find the termites, well, just getting a bone x-ray is not a great test for bone effects of hyperparathyroidism. DEXA, bone densitometry, the same as a 65-year-old woman, has a routine preventive measure on her 65th birthday should get. If you have hyperparathyroidism, everybody's got to get it. Because if you have a person with bone densitometry abnormal, time to get those parathyroids removed. Now, you do preoperative imaging of the neck. Now, that's not exactly a diagnostic test for hyperparathyroidism. Preoperative imaging of the neck with sonogram or nuclear scanning is helpful to determine a surgical approach. Means, well, those glands are small, and there's 4 of them. Which of the 4 are you going to remove? Ooh, I hope you're removing the right one. Ooh, boy, hey, I got some good news and bad news. What's the good news? Oh, I removed your parathyroid. What's the bad news? I removed the wrong one of the 4. Yeah, that would suck. So make sure you remove the right one. So when do I answer imaging of the neck or nuclear scintigraphy? And the answer is prior to surgery, to be sure you're removing the right gland, the one that's adenomatous. Remember, 80 to 85% that is an adenoma? Make sure you remove the one that's an adenoma. You can't necessarily tell by looking at it. It's a functional problem. It's like neurotic people are not uglier necessarily than regular people. You can't necessarily tell just by looking whether there's an abnormal function. For primary hyperparathyroidism, there is only one treatment in the long run, and that is surgery. Now, this is after you might get any acute symptomatic hypercalcemia controlled. See, this is the next step. So let's be clear that we're not talking about doing this for a person who comes in who's lethargic, confused, obtunded, stuporous, comatose, or having a short QT. And then you say, well, give me your neck, it'll fix it that way. No. After you control the acute symptoms with fluids and bisphosphonates and sometimes calcitonin, then if the parathyroidism is the cause of this, then you remove it with surgery. There is no medical therapy for primary hyperparathyroidism. No medical therapy for the hyperparathyroidism itself. For the calcium, yes, but not for the hyperparathyroidism. I remove the glands, and this is the last thing. I want to be crystal clear. If there's evidence of bone involvement, if there's evidence of renal insufficiency, if there's ever been a symptom of any kind, any one of those, in other words, any evidence of a clinical or laboratory manifestation of the adverse effects of that calcium disorder, is an indication to get rid of the gland. Hypocalcemia is low calcium, and low calcium means instead of being lethargic and slow and stupid and obtunded like high calcium, I can't move, and high calcium makes I can't move. Low calcium makes me twitchy, hyperexcitable, twitchy. High calcium makes me lethargic, and low calcium makes me twitchy, and hyperexcitable. If a high calcium makes it harder to depolarize, low calcium makes it easier to depolarize. The symptoms of the neural hyperexcitability are because the muscles and nerves simply depolarize more easily. And that is what you're seeing here, this is carpal pedal spasm or Trousseau's sign. This is a person who, when the blood pressure is blown up, their muscles become more easy to contract involuntarily in the arm. This is Trousseau's right here. Now, the same thing happens on the face with Trostick's sign. I tap, tap, tap the face, and the Trostick sign occurs when it causes facial spasm. Perioral numbness happens when people hyperventilate, like in a panic attack. Hey, oi, hey, hey. And they get perioral numbness from decreased free calcium. Decreases the free calcium. Mental irritability happens as part of the hyperexcitability, and ultimately seizures. That's the worst form of hyperexcitability of any kind. Hypocalcemia gives an EKG, which shows a prolonged QT. This prolonged QT can cause an arrhythmia, because as it prolongs, it starts to stretch, then it finally snaps and causes ding, 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 ventricular tachycardia. The treatment, of course, is simply to replace calcium and vitamin D, and that will cover it.